Hello, everyone. So this is the last lecture on renal and urinary problems, and as part of the Adult Health 2 course. So the first case study. So we have two chapters here, two content areas. Um, the first one, the care of patients with urinary problems, which will focus on the urolithiasis, which is the kidney stones. Non-infectious diseases, urolithiasis. Lithiasis means stones. So urolithiasis means stones either in the kidneys or ureter or the bladder. So that's in the kidneys, stones in the renal system, urolithiasis. And then the second chapter, care of patients with kidney disorders, we focus on the urinary tract infections, UTI, pyelonephritis, and the AGN, acute glomerulonephritis. Okay, so the first case study, the 48-year-old woman complaining of dysuria is diagnosed with the UTI, and that's as a result of the urinalysis, UA. The culture of the urine specimen and the sensitivity test reveal when we do the CNS, which is culture and sensitivity, we can isolate the microorganism, the type of bacteria, one or more, that are present and causing the infection and the urine specimen. So the CNS revealed that the causative organism belonged to the Klebsiella, and which is resistant to multiple antibiotics. So the nurse practitioner, based on these results, decided to begin the patient or put the patient on the aminoglycoside. That's the classification of the med, and one of them is called gentamicin, which is aminoglycosides. So the first question before doing so, you would explain to the patient that antibiotics such as gentamicin are associated with which of the following. So when we say aminoglycosides or like gentamicin, amikacin, gentamicin, uh, these meds are toxic to the ear and the kidneys. So they adversely affect the ear and kidney. So the answer would be, for the first question, is B, which is nephrotoxicity. So aminoglycosides such as the gentamicin, they accumulate in the proximal tubular cells of the kidney, and which will result in a defect in the renal concentrating ability, and that would reduce the GFR, glomerular filtration rate. And that takes a few days until it will significantly lower the GFR. This is a renal impairment, but this is always reversible. When that happens due to the aminoglycosides like gentamicin use, this impairment is reversible. Patient's GFR declined less than 60, that can be reversed and can be fixed. Of all the aminoglycosides as classification of meds, gentamicin and topramycin are the most nephrotoxic. And as we know all, we covered this in the eye and ear problems, that the aminoglycosides may also cause ototoxicity, and that would be in the form of irreversible auditory or vestibular damage, because it will damage the nerve, so it will result in irreversible hearing problems and hearing loss if that happens. There is a direct relationship between aminoglycoside dosage and the risk for the development of ototoxicity, which is the toxic to the ear. So, which means that doses should be adjusted according to the patient's baseline renal function. So we have, before we do the prescribe the drug, we have to run or ask or request for a baseline renal function test. Second question was, which of the following would lead to the classification of this patient's infection as complicated? Now, the answer for this one also, which is, sorry, with this, which is question number 3. So let's go back to question number 2 first. We'll jump into question number 3. Which of the following irreversible complication is also associated with the gentamicin use? So we did answer the question while I was talking about the 2 main complications that could result or may result from the gentamicin or aminoglycoside in general, especially gentamicin use. And we said renal nephrotoxicity. And then the second one was ear problems, which is hearing loss and ototoxicity. And that's in the form of the irreversible vestibular dysfunction or damage, because that results in damage to the nerve, vestibular nerve. So vestibular dysfunction or damage would result. So that's A, the answer. And then the third question, which is which of the following would lead to the classification of this patient's infection as complicated? Now, it's a diagnosis of type 2 diabetes. Now, complicated UTIs, they involve the metabolic or hormonal abnormalities, such as those seen in patients with diabetes mellitus or during pregnancy. The presence of foreign bodies, such as the renal calculi or kidney stones or tumors or catheters like Foley catheters, or the presence of strictures causing the strictures, which is the stenosed area in the renal system, especially like in the ureters, they cause a turbulent urine flow at the junction between the bladder and the ureter. The incomplete voiding, like such as that seen in patients with a neurogenic bladder, prostate hyperplasia, patients with prostate cancer, all of these are will be listed as a complicated UTI. So it involved the metabolic or hormonal abnormalities. And we mentioned patients with diabetes mellitus or during pregnancy. We said the presence of foreign bodies such as the renal calculi, the kidney stones, tumors, polycatheters, the presence of any strictures and stenosed areas in the renal system, which will result in turbulent urine flow, especially at the juncture between the bladder and the ureter, and the incomplete voiding, like when it's the incomplete voiding, such as that seen in patients with a neurogenic bladder, prostate hyperplasia. All of these are listed as complicated UTI. If the patient develop UTI from these factors, that will be a complicated UTI. Now, the post-voidal, when say post-voidal residual, The post-void residual volume greater than 50 up to 100 ml suggests abnormal bladder emptying. So 25 cc or ml is within range. Less than 50 is within range. 50 up to 100 residual in the bladder after voiding, that is abnormal, which would predispose the patient or individual to develop the UTI. So any individual who would have an amount of urine after voiding over like a 50 up to 100 residual, that is abnormal, and that would be a risk factor for the development of the UTI. So 25 is normal. The history of recurrent UTI does not in itself lead to the classification of subsequent infection as complicated. And due to the anatomic differences in urethral length between males and females, any UTI in a male is considered complicated. The history of recent surgery does not correlate with the development of the complicated UTI, unless the surgical procedure resulted in the creation of some anatomic abnormalities, changes in the renal system, which would increase the risk of infection. Like, for example, an example of this would be like, post due to the surgical resection or surgical procedure, if like in strictures or adhesions or strictures had resulted from the surgery, then that becomes complicated. A 6-month-old female infant is brought to the emergency room with vomiting and fever of 2 days duration. On examination, the infant is lethargic and appears dehydrated, but has no other focal findings. White blood cells elevated, chest X-ray is clear, and the straight cath urine specimen shows the presence of white blood cells and bacteria. What organism is most likely to be responsible for this infection? So there is a UTI, there's a urinary tract infection. This is an E. coli. After the first 4 to 6 weeks of life, so I'm going to answer or explain all the options here. So this is about A, which is the group B, why it's not group B streptococcus, which is GBS. Now, so after the first 4 to 6 weeks of life, the GBS begins to diminish as a cause of the urinary tract infection. The most common cause of UTI then becomes the E. coli, type of bacteria called E. coli. That's the most common one, causing most of the patients with UTI, they develop that due to the presence of this E. coli, this type of bacteria. And the UTIs are more common in females than males. If infants develop a fever and some degree of toxicity, like vomiting, poor feeding, being lethargic, they are commonly, would say that high likely that they are being diagnosed clinically with pyelonephritis. And even pyelonephritis, because we have UTI, upper UTI and lower UTI. Upper UTI infections and lower UTI infections. Like cystitis is a lower UTI infection. Pyelonephritis, it's an upper UTI infection, because that affects the pelvis of the kidney, upper UTI. So pyelonephritis is in upper UTI infection. So if infants develop fever and some degree of toxicity, like vomiting, poor feeding, being lethargic, they are high likely will be clinically diagnosed with pyelonephritis. And the best clinical way to document the pyelonephritis without any doing or requesting for any imaging, like X-ray or CT, or would be seeing the presence of the white blood cell cast in the urinary microscopic examination. The presence of white blood cells and the leukocyte esterase and the white blood cells and the leukocyte esterase and nitrites, they indicate definitely there is a UTI or the pyelonephritis. Next is urolithiasis. So case study in the emergency department, my back hurts. There's the vital signs. Here's the HPI, the history of present illness. Past medical history, review of systems. So we have 3 different levels of kidney stones in terms of the presence of the kidney stones. Like when the stones on the upper urethral ureter, like in the upper ureter, and the mid ureter, or in the distal ureter. Upper, mid, and distal. You see how the pain is going to be different. If the stone is in the upper ureter, then that will radiate to the flank side. If it's in the mid aspect of the ureter, then it will radiate anteriorly. And then it's when the stone is located in the distal ureter, so that will radiate to the groin, because that will be close to the urethral vesicle, which is close to the bladder. And the pain will change. The experience of pain, intensity, and location or site will alter or change as the stone is moving down the renal system, down from the kidney to the ureter to the bladder and then to the urethra. So the extent and the location or site of pain will change based on the presence of the kidney stone. And most of the time, the presence of the kidney stone, when it's stagnant, when it's dormant, it's not moving, it doesn't result in pain. The pain would begins when the stone begin or start moving and traveling from its location or from the place or site on which the stone was formed down the renal system. So what is the most likely diagnosis? So this is a nephrolithiasis, which is or urolithiasis, which is a kidney stone, or renal stone. Because when we say a renal stone, and that stone can be located anywhere in the renal system: kidneys, ureter, bladder, urethra. So the acute onset of severe flank pain radiating to the groin with hematuria that indicates renal stones, lithiasis, urolithiasis. The pain will become like on and off in waves as the stone continue to pass from the kidney into the urethral system. And hematuria is common in patients with kidney stones. Not necessarily that all cases will have hematuria, but it's a very common manifestation as the stone is traveling, moving down to the renal system, and it may injure the mucous membranes. and the epithelial tissue injury would result in that hematuria. Um, and the hematuria can be gross or microscopic. Doesn't mean that we cannot, we don't see it, that it's not present. Sometimes it's microscopic. It can be detected and detected and identified and seen under the microscope. So hematuria can be gross, can see it, or microscopic under the microscope. Um, the the pyelonephritis, when the patient has developed the pyelonephritis, there is a CVA tenderness, which is the costovertebral tenderness. Recall this from the physical assessment course, and flank pain, as well as fever and dysuria. These are associated manifestations that are associated with pyelonephritis. There is a costovertebral tenderness, CVA. There is a flank pain, as well as fever and dysuria. The testicular torsion, that's an acute but presents with severe pain that starts in the scrotum. The emboli in the renal artery embolus, present with flank pain, and the patient has a history of recent cardiac catheterization or atrial fibrillation. The lumbosacral strain, which is simply back pain that you can elicit with palpation. Hypertension is not specific enough to be useful. And anything that causes pain, that definitely can also lead to hypertension. So we have four kinds of stones. We have calcium stones, most common type. Most common type is calcium stones. We have strovite, which is strovite stones, which is composed of three things or three elements: minerals, magnesium, ammonium, and phosphate. Strovite stones. And then we have uric acid stones and we have cysteine stones. The most common one is the calcium stones, calcium oxalate or calcium phosphate. What is the most accurate diagnosis or diagnostic test for this patient? The CT scan without contrast. The best test to evaluate for kidney stones is a CT of the pelvis without contrast. Ultrasonography, which is less accurate than CT and is only used in pregnant patients presenting with with nephrolithiasis. That's the ultrasonography. The calcium-containing stones are radio opaque, but um, the pure acid or the uric acid and cysteine calculi are radiolucent. And that's when we do the KUB, which is the kidney ureter bladder radiography. That's the plain radiology, KUB. The calcium-containing stones are radio opaque, but the uric acid, the pure uric acid, and the cysteine calculi are radiolucent on the KUB. The contrast is, which means using the contrast media. The contrast is contraindicated because the patient may already have renal compromise. You have to think of renal function test, renal impairment, or renal function, or any impairment that affected the kidney prior to the use of any contrast, because that may put another strain and more problems to for the kidneys. So contrast for using contrast media is contraindicated because the patient may already have renal compromise or impairment and decreased GFR. The intravenous pyelography, which is IVP, it's always it's not the correct answer. And the MRI of the abdomen also is not incorrect. It's an incorrect answer. The most common type of kidney stones, as we said, is the which the one is composed of calcium, either calcium phosphate or calcium oxalate. Now, the most common causes of the kidney stones are hypercalciuria, increased calcium content in the urine, and usually patients will become dehydrated, decreased fluid intake, and that's why most of the high prevalence of the kidney stone cases would be during the summertime due to that hydration reason or factor. So these are the orders: the urinalysis, CT scan of the abdomen without contrast, medications. These are the meds. So next question is, what is the next step in the management of this patient? Now, the answer would be all of the above. To adequately assess the stone to be removed or to pass through the renal system, the IV, so the IV normal saline, so that would be hydration will be number one. So first we have to start with the hydration, so IV normal saline, so that will increase urine production, and that will increase flow of the urine, combined with also pain relief. So we will give pain management for pain relief and antiemetic to cover or to stop the nausea and vomiting, if there is any. The alpha blockers, such as tamsulosin, which is Flomax, alpha blockers, which is like tamsulosin, which is a Flomax. The calcium channel blockers, such as nifedipine, they will assist in the dilatation of the urethra. Distal dilatation of the urethra can be accomplished from tamsulosin, which is alpha blocker, and the calcium channel blocker, like the nifedipine. So these are these strategies or management steps. They are used if the stone is borderline size, which is stones smaller than 5 millimeters, in which that less than 5 millimeters that will pass spontaneously through the urethra. However, stones larger than like 7 or 8 millimeters that will never pass spontaneously, no matter how long you wait and how much fluids you will give or your administer. It's not going to pass through the urethra because that's a large size, 7 or larger than 7 or 8 millimeters will never pass. So after, or there can be this step, which is very important, which is urine strainer that is needed to find the stone after passage and analyze it for the composition or the makeup of that stone. So it is one of the very important, significant step that we encourage patients once they been diagnosed or they confirm that they have kidney stones and they start taking the fluids and the medications and prior to stone being passed through the urethra is that they strain the urine. So use some type of urine strainer. That strainer is going to catch the stone, and when the stone is passed, and then it will be caught or strained in the strainer or present in the strainer, then that can be sent to the lab for analysis for the composition of the stone to be known so that identified to the patient. So we can also um, guide our treatment in terms of the prevention of subsequent stones and to teach the patient how the type of food that should be eliminated or should be, not to be consumed in moderation, or should be taken off the, the patient's, list of things to be eaten. So that will be dietary recommendations. Dietary recommendations is based on the analysis of the kidney stone. So straining or the urine strainer is very important. And that's also the same step we use after the lithotripsy, which is the breaking the stone into small fragments by the laser technology called ESWL, extracorporeal shock wave lithotripsy. ESWL, extracorporeal shock wave lithotripsy. So we call it lithotripsy, which is the splitting the stone in small fragments, and that will then easily pass through the urethra. And that same thing, post that procedure, right after the procedure, patients, once patients, home or right, leaving the center or the kidney stone um, lithotripsy center, then the patient should start using the strainer. Same reason, to trap and to catch all the kidney stones so they can be sent off to the lab for analysis and to know the composition of the kidney stone for better treatment and guidance in terms of dietary recommendations. So in general, stones less than 5 millimeters, they will pass spontaneously through the urethra. Stones larger than 8 millimeters, they will not pass spontaneously. So the first question, the answer is no urine output for 2 hours. The greatest risk to the patient is kidney damage, which may occur from the renal obstruction. So the priority finding is no urine output for the last 2 hours. The flank pain, and which radiates the abdomen, nausea, and sweating, all of these are important findings, but not the priority. The priority is no urine output for the last 2 hours. Number 2, the answer to the straining by urine following the procedure is important. So straining the urine, I just highlighted this earlier about straining the urine and capture the stone, which will allow for analysis of the stone, and the client will receive moderate sedation during the procedure, which is the ESWL, which is extracorporeal shockwave lithotripsy. Which usually they call it lithotripsy as a short term. The hematuria is an expected finding, and the lithotripsy is just break down the stone into small fragments that can pass through the urethra. So the lithotripsy, it doesn't reduce the risk of stone recurrence. Number 3, answer is reduce sodium intake in diet. See, these are the recommendations for a patient who being discharged after spontaneously passing a calcium phosphate stone. So reduce sodium intake in diet, increase fluid intake to 3 liters per day if not contraindicated, like patients had renal problem like end-stage renal disease or CHF or liver problems like liver cirrhosis, end-stage liver disease that is contraindicated. So report burning or dysuria to the provider and limit intake of food high in animal protein. So reducing sodium intake, increasing fluid intake to about 3 liters per day, reporting burning or dysuria to the provider, and limiting the intake to limit the intake of food high in protein and animal protein. All of these measures and steps will should be encouraged by the nurse. The rest of the interventions um, will not prevent the reoccurrence of the calcium phosphate stone formation. Pyelonephritis, we have another case study. And so the E. coli, we had a question earlier about the E. coli, the type of bacteria, most common bacteria that causes the UTI, especially pyelonephritis, which is the E. coli. So the E. coli is still is the most common cause of UTI of the urinary tract infections. So as we review the report, and especially looking at the white blood cells, it's 16,700. So it's extremely high, elevated. So we, within the urinalysis UA results, we can take a look at the two things, the bacterial, the nitrites and the esterases, nitrites and the esterases. These two findings would be elevated, and these indicates the presence of the UTI, the nitrites and the leukocyte esterase. Nitrites and leukocyte esterase. Anytime within the urinalysis, you see an elevation or presence of these two things, the nitrites and the leukocyte esterase, it indicates the presence of the UTI without even doing the CNS. It's just doing UA urinalysis without sending the specimen for ease culture, and sensitivity can tell from the UA the presence of nitrite and leukocyte esterase that there is a UTI. So pyelonephritis is an upper UTI infection, upper UTI, which means there should be systemic manifestations like fever, malaise, general weakness, chills. So when there is a dysuria plus white blood cells in the urinalysis, that's a UTI. But if there is a flank pain, then it becomes pyelonephritis. If there is dysuria, elevated white blood cells, plus suprapubic pain, so suprapubic pain with dysuria and white blood cells elevation in the urinalysis, then that is cystitis, because the pain is in the suprapubic pain or area. So that becomes cystitis. So pyelonephritis will be dysuria plus urinalysis white blood cells plus flank pain, pyelonephritis. Dysuria, urinalysis white blood cells plus suprapubic pain, that's cystitis. So orders is ceftriaxone IV, which is Rucephin, intravenous IV, renal ultrasound, now for the IV pyelonephritis, IV therapies for the pyelonephritis, ceftriaxone will be one of the on the top of the list for Rucephin, ceftriaxone. You can give also ampicillin and gentamicin. The ciprofloxacin, which is fluoroquinolone. Levofloxacin also is fluoroquinolone. But we have to be careful with dealing with the side effect of the tendonitis, especially Achilles tendon inflammation. So the renal ultrasound is requested too, because you can identify if there is any stones, strictures, tumors, obstruction. So reports, the renal ultrasound came back, no stones, no hydronephrosis. There's an enlarged left kidney, which is an edema, which is consistent with the pyelonephritis. Now, what are the other indications that may confirm that the patient, or at least assist us to think of pyelonephritis? The main reason to admit the patient, and then patient should be admitted for pyelonephritis. Pyelonephritis should be treated in the acute care setting. So that's why the patient should be admitted to the hospital. So the reason to admit the patient to the hospital is when there is inability to take pills. Patient cannot take pills. So because we have to administer the IV antibiotic. The pills is not, or tablets is not going to, to take care and to treat the pyelonephritis. So the patient should be admitted to the hospital to receive the IV antibiotics. In addition to, patients should receive also other antiemetics intravenously for nausea and vomiting as a common sign or symptom of pyelonephritis. In addition to, they become some of the patients with pyelonephritis, they become hemodynamically unstable, especially with the hypotension and cardiovascular problems could result. So no growth after 3 days. That's the report of the blood culture. But the urine culture indicates or isolated E. coli, and then still the sensitivity result is still pending, which means the CNS, which is culture and sensitivity, it takes few days. First, you will have the isolated bacteria, or the type of bacteria which has been isolated in the lab or in the specimen, and then you will get the report on the sensitivity for each bacteria, which bacteria is sensitive to what type of antibiotic, if it's sensitive or resistant to what. So let's say that we have only one organism, E. coli. Then they have a list. They will provide you with a list of antibiotics, and next to each one, it will see the bacteria is going to be sensitive or resistant. So, which means that we have to, patient should receive the antibiotics in which that the bacteria is going to be sensitive and not resistant, against the antibiotic. Next question is, a 40-year-old woman presents with a 4-hour history of flank pain. So this is a classic case study, or a patient who was experiencing pyelonephritis. So detection of the white blood cells leukocyte casts, that is the indication that it's a pyelonephritis. Common symptoms would include fever, chills, nausea, vomiting, diarrhea. So there is a systemic manifestations. Flank tenderness, also very common manifestation of pyelonephritis, which is flank tenderness over the affected kidney. And it can affect only, most of the time, it only affects only one side, one kidney, which is, pyelonephritis is different than the glomerulonephritis, AGN, which is an autoimmune disease which affects both kidneys. Pyelonephritis affects only one kidney. 11-month-old girl presents to your office with fever. So collect a catheterized specimen. So the B is the correct answer. Now, urine for urinalysis and culture, which is CNS, must be properly obtained. Urine specimen for UA, culture, and sensitivity, so CNS. And catheterization is the most reliable method among all the methods of urine specimen collection when it comes to sterile technique or sterile specimen to be obtained. The bagged specimens are not recommended because of possible skin or fecal contamination of the specimen. And similar to that, obtaining this, the sample from a diaper or from body would be unacceptable. Next question, the answer is B, which is admit for IV hydration and IV antibiotics. Leukocyte esterase, which is an enzyme in white blood cells, and the nitrites, they both suggest UTI. Microscopic analysis of white blood cells over 10,000 is predictive of an infection of a UTI. And when the patient develops a UTI, the red blood cells are often present as well. And the most appropriate course of treatment would be IV hydration and the use of empiric treatment, like with antibiotics, like ceftriaxone or cephin, while awaiting the culture. So we will send the culture first before you start the antibiotic, send the cultures, and then right away after you send the specimen, then you will start the patient on IV fluids and and IV antibiotics. That's the anticipation of the plan or the care plan for a patient with pyelonephritis. So the answer is E. coli, and we answered this question earlier twice. E. coli is the most common organism in the urine culture when the patient develops UTI. Next question, the answer is A, decreasing urine white blood cells. Next question, the urine correlates increased risk of pyelonephritis in clients with history of renal calculi, which is an expected outcome for the older adult male client with a history of asthma who is being treated with macrobid or nitrofurantoin. It's flu-like symptoms. That's one of the expected side effects. Now, the nitrofurantoin, which is macrobid, that comes in usually patients with the recurrent UTIs, older adults, when they have a increased like recurrence of the UTIs, then they will be put on nitrofurantoins like macrobid, small dosage like maintenance, like a daily dose of 50 milligrams tablet, for example. That's preventive measure. That's prophylactic because they tend to develop the UTIs and they have experience in the past that with the high rate of or frequency of to develop the UTI. Next question, the answer is 1, 4, 5, and 6. The prolonged recovery time, which may take 2 years. And this is an AGN. This is acute glomerulonephritis. And that's an autoimmune disease in which there is an antigen antibody complex that is going to be deposited on the basement membrane of the glomeruli. So the basement membrane of the GBS, we call it glomerular basement membrane, that will these deposits of the antigen antibody. So due to it's an autoimmune disease, these deposits of the complex on the basement membrane of the glomeruli will result in damage to the glomeruli, and then eventually there is a renal problem, dysfunction, impairment. So it's a post-streptococcal glomerulonephritis. Now it's post-streptococcal because most patients, and it's usually at the childhood age, like children who develop this, once they develop the like upper respiratory tract infection or any strep infections, and then it will travel to the kidneys and cause this autoimmune disease. So the answer would be 1, the prolong. So it affects, first of all, it affects both kidneys equally. Now, like the pyelonephritis, it may affect only one side. Here, it's an autoimmune disease, so it's in the blood, so it will affect both kidneys equally. So first of all, the answer would be the prolonged recovery time, which may take 2 years. And then 5 and 6, which is weighing the child daily to determine the fluid retention or loss, because one of the major complications is the protein leakage in the urine, protein loss, which will result in edema, facial edema, preorbital edema, which is edema around the eyes, and generalized edema. So giving an antihypertensive if the diastolic blood pressure exceeds 90. So the recovery period may be as long as 2 years in AGN, acute glomerulonephritis. We call it AGN. Fatigue may restrict the return to the previous activity level. After 1 to 2 weeks, the child can attend school, can engage in normal activities, can expect competitive like activities and be involved in the social and school activities. Number 3, the acute post-streptococcal glomerulonephritis is not infectious. So it is, we said it's caused by the antigen antibody inflammatory response to a past infection. Patients usually develop the streptococcal, or in fact, like upper respiratory tract infections with the strep infection, and then they develop this AGN. The antibiotics are usually ineffective because the disease is caused not by an active infection, but by antigen antibody inflammatory response. And the best indicator of the fluid loss or retention of fluid is daily weight. Sodium restriction may be needed to control edema, but most children, they do well on a normal diet with normal salt and protein content. Antihypertensive drugs and therapy with calcium channel blockers is used to treat diastolic over 90. Next question, the answer is about the AGN2. It's number 1, all children with glomerulonephritis will develop chronic disease. A few children with the acute post-streptococcal glomerulonephritis will develop the chronic disease. But many of these cases are believed to be different glomerular diseases, which is usually misdiagnosed as the post-streptococcal disease. Death from the complications of the acute post-streptococcal AGN is, fortunately, it's very, it's rare. So that statement is correct. Almost all children who are correctly diagnosed with AGN, with acute post-streptococcal AGN, they recover completely. Completely, they are recovered from this disease. So this statement is correct. So specific immunity is conferred so that the subsequent recurrences are uncommon in the acute post-streptococcal AGN, and this statement is correct as well. So AGN, acute glomerulonephritis, and most common type, which is the acute post-streptococcal type. Now, the clinical manifestations, we said edema, which is present in about 75% of patients or cases with AGN, especially the facial edema, the face, the eyelids, the hands, urine, hematuria, microscopic or gross hematuria, and the urine color too. The patient will report urine color changes like smoky color, reddish color, brownish color, rusty. Patient will have also oliguria or dysuria, moderate to mild to moderate hypertension, elevation of the blood pressure, nausea and fatigue, and nausea and vomiting, and that's if the patient developed uremia from renal failure. So the glomerular injury would result in proteinuria, the loss of protein in the urine. That's why the patient developed the edema, facial, eyelids, and hands edema. That's due to the loss of the protein in the urine. Hematuria, decreased GFR, edema, hypertension. All these are manifestations of AGN. The answer to this question, which is the older adult client with acute AGN, often diagnosed with CHF. The least common manifestation of acute AGN is more likely to occur in older adults. So the fluid overload, which will dominate the clinical picture of a patient with AGN, can be easily confused with CHF because of the fluid overload. Answer to this question would be Edison's disease. And next question, the answer is polyuria, hypotension, headache, dyspnea, and bradycardia. And the last question, which is a 6-year-old, which is about the IgA nephropathy versus AGN. 6-year-old boy present with a gross hematuria and no other symptoms 2 days after a sore throat. So sore throat shows there is a strep infection, streptococcal infection. So kidney biopsy reveals proliferation on light microscopic IgE deposits on the immunofluorescence. This patient is experiencing an IgE nephropathy. This might be a slightly advanced question. I'm not like asking even students who need to know what is the IgE nephropathy, but just to know that it's very easily patient can be misdiagnosed with AGN and be treated as if it's AGN. So the IgE nephropathy, which is called Berger disease, B-E-R-G-E-R disease, Berger disease, B-E-R-G-E-R, which is an IgA nephropathy, which is the most common form of acute glomerulonephritis worldwide. So this is a form, one of the specific forms of the glomerulonephritis, acute AGN, worldwide, and especially in Asia. It is the most commonly seen in children, with in terms of the prevalence in boys, outnumbering girls 2 to 3 times. So the numbers in boys, they outnumber the prevalence or numbers in girls about 2 to 3 times. And it's present. So the IgE nephropathy, which is a Berger disease, which is a form of AGN, it presents with gross hematuria 2 to 3 days after pharyngitis. So after patient has the pharyngitis with a streptococcal infection or a GI infection, then 2 to 3 days after that, it will travel to the kidneys and it cause the IgA nephropathy, which is a form of AGN, acute glomerulonephritis. And then about half of the children who develop this, they progress to renal insufficiency. The difference between this IgA nephropathy, Berger disease, and the post-streptococcal AGN is that the post-streptococcal AGN, it's also post-infectious, but presents 10 days up to 2 weeks after the streptococcal pharyngitis. So if the patient or the child develop pharyngitis with streptococcal infection, if they develop the AGN 10 days up to 2 weeks after that pharyngitis, then that is a post-streptococcal AGN. But if it takes like 2-3 days after the pharyngitis, then they start to have hematuria and then renal problems, that is an IgA nephropathy, which is a Brugger's disease. That's the difference between, because there are too many types of the AGN. So that's the difference between the IgA nephropathy and the post-streptococcal AGN. In terms of the number of days in which the patient will develop the signs and symptoms of renal impairment after being diagnosed or being experiencing the pharyngitis with the streptococcal disease. So this concludes our lecture today.